Welcome to InfoCardia, where we aim to summarize landmark cardiac clinical trials in under 10 minutes. Whether this is a first-time video or you're a returning subscriber, please consider subscribing and following and sharing as we continue to push out informative summaries of landmark clinical trials. Alright, so today we will be discussing another trial related to atrial fibrillation. As mentioned in the previous video, AFib is the most common heart arrhythmia around the world, affecting over 6 million Americans, and this number is actually expected to double by 2030. AFib causes approximately 450,000 hospitalizations each year, and arguably for that reason alone, it's imperative to study the causes and treatment and what can be done for this pathology. This trial was deemed the East-Afnet 4 trial, or the early rhythm control in patients with atrial fibrillation, generally less than 1 year. Published in 2020, this trial came after the AFFIRM trial of 2002, as discussed in the previous video. The AFFIRM trial aimed to randomize seniors with atrial fibrillation to either a rate or rhythm arm strategy, and it found a trend towards increased mortality with a rhythm control strategy. However, this trend was not substantiated or noted as clinically significant, as the p-value was found to be 0.08 greater than 0.05. This trial certainly had its shortcomings, while it is certainly deemed as a landmark trial for giving us an insight onto how to approach atrial fibrillation. Some of the shortcomings included not assessing for early or late rhythm strategy, the discontinuation of anticoagulation after 4 weeks of therapy. Additionally, the rhythm agents used, specifically referring to amiodarone and its multiple side effects. Now, while the AFFIRM trial seemed to suggest that rate control should be the initial treatment option for atrial fibrillation, the East-Afnet 4 trial aimed to tease out some of the shortcomings of the AFFIRM trial and, in short, ask the question, in patients with recently diagnosed atrial fibrillation, can early rhythm control reduce the risk of cardiovascular mortality, stroke, heart failure hospitalizations, or ACS hospitalizations? And specifically in regards to this study, the term recently diagnosed was defined as less than 1 year, and interestingly, the median time was 36 days. Now let's talk a little bit about who was and was not included in this study. The inclusion criteria generally included patients with atrial fibrillation diagnosed less than 12 months before enrollment. Generally, they needed to be 75 or older with prior TIA or stroke history, or 2 or more of the following. This list was generally similar to / related to the CHADS-2-VASc scoring system that we often utilize in atrial fibrillation when we talk about need for anticoagulation and risk stratification. Specifically for this study, this list of 2 or more referred to the following: age equal to or greater than 65, female sex, heart failure, hypertension, diabetes mellitus, CKD stage 3 or 4, and LVH, which was defined as diastolic septal wall width greater than 15 millimeters. Understandably, the exclusion criteria included patients with a life expectancy less than 1 year, those with substance use disorder, those with prior atrial fibrillation procedures referring to ablation or surgery, previous therapies including amiodarone, prosthetic mitral valves, or severe mitral stenosis, and clinically relevant hepatic, thyroid, or renal dysfunction. As demonstrated by this chart of demographics and comorbidities, patients were fairly evenly distributed amongst the 2 arms of early rhythm control and usual care. Looking a bit more into the 2 arms of the studies, those patients placed in the early rhythm control categories were treated with antiarrhythmic medication or ablation and cardioversion of persistent AFib. Medication choices for antiarrhythmics were chosen by the local investigators using protocol guidance. Participants also collected a single lead EKG twice weekly when symptomatic, and any recorded atrial fibrillation did trigger an in-person visit from the study team for drug escalation. As you may have guessed, those placed in the usual care group were treated with rate control without rhythm control, except those with uncontrolled atrial fibrillation. Looking a bit more at this graph, specifically the early rhythm control arm, as compared to the AFFIRM trial, had a heavy reliance on amiodarone and sotalol, its rhythm controlling agents. In this trial, there was an increased prevalence with the use of flecainide and an increased use of dronedarone, the cousin to amiodarone, with arguably less side effects. Additionally, ablation was relied upon as a significant means of treatment, up to 19.4% at the 2-year mark in the early rhythm control arm. And in regards to anticoagulation, as compared to the AFFIRM trial, where practitioners had the option to discontinue anticoagulation after 4 weeks of AFib-free, in this study, anticoagulation was continued for the duration of follow-up. Notably, the trial was stopped early with 5 years of follow-up because of efficacy in the early rhythm control arm. So again, in summary, this trial aimed to ask the question in patients with recently diagnosed atrial fibrillation, can early rhythm control reduce the risk of cardiovascular mortality, stroke, heart failure hospitalizations, or ACS hospitalizations? And what did we find? In conclusion, we saw that the early rhythm control group had a lower risk of cardiovascular mortality, stroke, heart failure hospitalizations, or ACS hospitalizations, as well as the individual outcomes of cardiovascular mortality and stroke. This is outlined in the table showing the first primary outcome of what we just mentioned, with a treatment affect of 0.79 and a p-value of less than 0.05, specifically 0.005 was the value deemed clinically significant. This is further depicted in the graph illustrated here, showing the comparison between years since randomization and cumulative incidences, where we see usual care had a higher rate of incidences and mortality as compared to early rhythm control. Now, while this trial came with its own shortcomings, overall, the trial supports the use of early rhythm control strategy for atrial fibrillation over rate control strategy. Whether anticoagulation may be safely discontinued amongst patients receiving early rhythm control is unclear and was not properly investigated in this study. These findings have contributed to the changes in the recommended guidelines. As of the recording of this video, the updated guidelines call for a stronger, more prescriptive focus on healthy lifestyle habits to prevent or lessen the burden of AFib, as well as early and more aggressive rhythm control in general, including upgraded recommendations for catheter ablation as a primary focus in the prevention of disease progression. And with that, we thank you again for joining us on InfoCardia and welcome you to subscribe to stay up to date on our latest videos as we aim to summarize cardiac clinical trials in under 10 minutes.